Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
What? I'm so excited. I lost my voice. So excited for the YouTube live stream of the Auburn Medical Group with Stephanie, the PA student.
Hello.
She's back. Here she is. Second time. How often do you see that? Then they go, yeah, I'll do it a second time.
It was so good.
She had a great experience in this very crowded studio that we have.
That's right.
So we're going to be talking about the Netflix series Painkiller, which some of you hopefully have seen since we're going to be talking about it.
I have not.
I have not.
That's 1 out of 3 for us.
We can talk
but
about
I know the story, so I can.
We lived it.
I can. Yeah. I can.
Well, thankfully, not the really bad
parts of it. Yeah.
true experience. Yeah, I'm not sure how much to say. We will go ahead and put out the warning that there are spoilers just to protect ourselves. That way, people can't come back later.
I don't know because I haven't seen it, but I know history.
Yes.
I know the story and about the
family. You know that,
and
time and
the company and all.
Yeah. Do you know anything about OxyContin and the Sackler family? And
nope.
Okay.
All right.
Well, you're coming in fresh. Your career will be different from ours.
Ooh, definitely.
In that you didn't practice during that time of hopefully not as much pressure to inappropriate prescribed medicines from patients.
Yeah.
And that's an interesting thing.
Even non-opiates,
Yeah.
Other things as well.
Yeah, I think I told you a little bit about the first episode. So that's what we'll be talking about before I jump into it. We also have our live stream because this is a live stream. And so people are on the chat. Specifically, we have on the chat, let's see how to do this here. On the chat, we have, no, this is me asking the question, but Lindsay Antwine
Killers.
wants to know what it's about. Well, Lindsay Antwine, it's about the Netflix series Painkiller. Oh, you knew that. It's about...
She knows that part. She just don't know what it's about.
It's about OxyContin. It's about Purdue
Pharmaceuticals.
Purdue Pharma or Pharmaceuticals.
I think it's good.
The Sackler family that owned Purdue. That was the name of their company,
Yeah.
Purdue, but it was the Sackler family's company.
And a lot of knowledge of stuff that they covered up yet. And they got in a lot of trouble.
Yeah. Matthew Broderick plays Richard Sackler, I believe.
Does he?
Yeah. It's kind of...
Yeah.
It's funny to see Matthew Broderick as the old guy there. And he does a great job.
Ferris Bueller.
Yeah, Ferris Bueller is drugging the country.
Pushing drugs.
It's interesting. So it is. I'll say it's a documentary. I hestate to call something a documentary that has
fictionalized
that,
some of it, but.
Or docudrama, I guess is what it is, because they're dramatizing something that actually happened, and
there are plenty of documents backing up all this.
It's still a drama. It's still a drama. It still has script made up, obviously.
Yeah.
But yeah, it's easy after the fact,
right,
to make a bunch of people the bad guys when people die.
Sure. Yeah.
I'm thinking in terms of it from my perspective of, should I say, my role in it? I'm trying to think, did I prescribe OxyContin? I think there were times that I did. And that
there were a few times I did.
And that I was convinced of the argument in favor of its prescribing.
Mm-hmm.
Thankfully, I don't believe that anybody I prescribed it to ended up being a victim of the really bad things that happened. People died. People got addicted to opiates on OxyContin.
Yeah.
And you kind of look back and over a long career, you don't know for sure.
Yeah. But
I don't remember prescribing in a manner that was irresponsible and that would lead to that happening, as you see happen in the Painkiller series.
Right.
And of course, with the way we do it now, I think I have 2 patients who return monthly for their pain medicines, and we're not adding to that for opiate for chronic pain control. We don't bring people in who are on those medicines. You need to stay with whoever started you on that, because it's not our job to detox you when somebody else started you on it. That's patient abandonment if they don't stay with you after starting you on it. So that's why it's such a big deal not to start it in the first place.
Yeah. So tell me, I mean, the movie or the docu-series, whatever it is, tell me your experience, though. Maybe we should start with that.
Do you want to just get some comments out of the way and then jump back to... Okay, so we'll get a few comments. We've got Hilda Bauer saying, what was covered up?
We'll get into that.
We'll touch that. Thank you. Tokyo Lloyd, is there a way to start a petition to get OxyContin back? The cartel fentanyl makes me feel weird, and I don't like it. Okay. Thank you, Tokyo Lloyd.
I don't know if you're serious, but
that brings up a good point.
It did get a lot of people into that market, unfortunately.
We usually think that humor is as important as medical information because humor itself is a medicine.
Yep.
And if somebody watching this lost a family member to OxyContin, we are deeply sorry.
Yeah,
and
that's all right.
We ask you probably not to watch this program much further, respectfully. Because we do joke around quite a bit, and we absolutely do not want to make light of somebody's family experience of the horrible things that this has done.
Yeah, it's definitely a more serious topic here, so we'll try to lighten it up as best we can.
And we have a member on the channel, Maria Ortega. My daughter and granddaughter passed away due. Gee.
Oh, wow.
Yeah, Maria,
Wow.
we
daughter and granddaughter.
thank you for being a member of the channel. You got a little icon right there.
I'm so
That's
sorry to
kinda
hear
cool.
that.
Yeah. You know that if you watch us, if you're a channel member, you probably know that we like to joke around a lot, and this isn't a joking matter. So
Yeah.
but that's kind of what this show is. So forgive us for some things that may be coming up.
Right. Yeah, maybe a place to jump off there is fentanyl. So fentanyl is the current
Maria gives us the
strong opiate that's on the streets that everybody is, unfortunately,
kind of replace the
is very addictive,
OxyContin,
very strong. It's very quick on, quick off, which unfortunately makes it even more addictive that you need to get more and more often. OxyContin preceded that, and OxyContin got a lot of people onto heroin. So kind of the progression was, if there's a straight line from the Sackler family and Purdue Pharmacies producing OxyContin, which then led to heroin users, which now has led to fentanyl.
And I believe that,
unfortunately,
I could be wrong, but I believe the use of heroin was a substitute for
for OxyContin. Yep, because you couldn't get it on the street sometimes. So that unfortunately would make people street drug users.
And that happened.
It did happen. And the problem is early on, there was this, the Purdue Pharmacies put out this thing saying, hey, it's okay if a doctor is prescribing it and you're under a doctor's care, there's no way you can get addicted, which we now know is not true.
The famous statistic is 1%.
Yeah, that's what they said. This is not the real.
And I'm trying to remember where they got that number from. In the documentary, in the series Painkiller on Netflix, they have a way that they come up with that, and it's not at all a legit thing to be putting out there in their materials, which is actually what happened according to. I don't remember seeing that myself. I do remember the argument, though. I was there when this drug was being promoted, and thankfully most of it was after we went independent and didn't have drug reps in our office. While we were watching it, Leanne actually turned to me and thanks me during the movie for not letting drug reps in the office, because it kind of shows what's going on here. Oh,
what
Lindsay,
they do, yeah.
If a doctor says so, it's good for you, right? Yeah, see, that's exactly what happens in the program. Yeah, if a doctor prescribes it,
and if somebody can convince that doctor, then even better, right?
So you read that thing today in the lawsuit about Dr. Feelgood, who was prescribing crazy amount. What was it, 300 a year or a month? I mean,
no, he was. I forget what the 300 was. It was visited over 300 times.
By the drug rep.
Drug rep,
the drug rep.
A year, which is a ridiculous amount.
Doing what it takes to make it worth it to him.
Probably giving them all these kickbacks.
And if you watch the movie and see how they're selecting the physical appearance of the drug reps, that's not an exaggeration. I remember when I was in residency, those drug reps.
Yeah.
Or even where I worked before we opened here. Yeah. You do too?
Oh yeah, absolutely. I mean,
they knew that most doctors were men. That's a quote in the show.
So they have young, well,
back then,
good-looking women who dressed
Professional.
somewhat professional.
Yeah, that's a reality. I'm here to tell you that was really what they were pushing us. And particularly, I think of my orthopedic surgery resident. And of course, that was tramadol back then before or OxyContin, because OxyContin came in the early 2000s is where it was really getting strong.
Really getting
Yeah, so I was kind of on my way out of residency into emergency medicine. And at Kaiser, we didn't have much as far as drug reps. Yeah. It was more after I got out of Kaiser, was in urgent care that the drug reps would come in. And we'd hear these arguments, but it felt to me like it was coming from, like for the state of California to require that training on pain that occurred like around the time the OxyContin was a big thing. I really wonder if Purdue had something to do with all of that training that we were put through.
I don't know what training you're talking about.
Oh, I'm trying to think. Okay, now you're required in California.
Because you do have training now.
To have, is it 5 hours? You had it through your residency.
I did, yeah.
Yeah. Because it was integrated.
Because coming out of my residency, I had a fair amount. I in my residency, and then afterwards, I worked at a community clinic. Lots of people on disability, so they have chronic pain, and there were a lot of narcotics and opiates, and I inherited a lot of those people when I started to work at that. And for some reason, and I don't think it was taught to me, I think part of it maybe was my internship with you. I kind of went into it having kind of a bad taste in my mouth for narcotics and tried to distance myself from them as much as possible. And I'm glad I did, and I don't know how that happened, but I try to minimize them.
I think about a lot of the people who came through residency the same time I did, with classmates and such from medical school, and wonder, how many of them may have been caught up in this, because it shows the doctors listening to drug reps. Thankfully, we got rid of that long ago, and then prescribing based on the information they're getting from them, with things like OxyContin is safe. Safer than other things. One of the arguments.
I remember them saying that. Yeah.
One of the arguments is
it's a pill that
it lasts for 12 hours, so you're not going to have the withdrawal effects to reinforce addiction. So that they'll just take the next pill at 12 hours. And of course, the show points out it wears off before 12 hours.
Right.
And the patient has this incentive to increase it.
I remember my attendings knowing that, like saying that, okay, if you're going to give like an extended release pill, don't give it every 12 hours. Give it every 8 hours. Because somehow they knew that, either from experience with patients or something like that. Yeah,
and I don't know how real it is, but I'm sure it happens somewhere. In the program, they show that it's wearing off. Its effects wearing off. And so their way of addressing that, instead of prescribing it 3 times daily, was to up the dose. So to go from 20s to 40s, from 40s to 80s.
Yeah, which is still going to wear off at the same time.
And because it was not generic at that time, they charged more
for the higher doses.
They charged by the milligram, not by the pill.
Interesting.
Which with generics, it's usually closer to, not exactly, closer to by the pill rather than by the number of milligrams in the product. Let's look at our comments here. We have Tokyo Lloyd saying, "Oh wow, you guys are in the show."
You are too. What do you know?
This show, not that show. Painkiller.
We're not in Painkillers. Yeah. Stephanie,
what's up?
You are going through your training right now.
Yes.
I'm sure you had training on narcotics and prescribing narcotics.
Mm-hmm.
I'm curious how your experience was different than ours, being first a PA, so maybe coming at it from that perspective, and then also being trained now, 20 years later after all this happened.
It's harder to say. I'm just wrapping up my education as a PA student. I see it like these drugs being prescribed on clinics. And I guess the biggest takeaway that we've learned in school is using all of the technology that we have now to check patient compliance, different websites, like is it your, we use eForce over in Florida.
Cures here in California.
Just to check if patients are using their medication properly. And
Okay, you're in your Dutch brothers. Good.
Good. I'm glad they're teaching that, because that is part of this training that actually we need to go to that we have gone through that's required by the state of California. So with each pain medication you prescribe, you should be checking this. They're by state, so it's a state registry of every controlled medication. Every state has them. And actually now you can check like surrounding states too, which is kind of nice, so people can't, doctor shop across borders. But that's one thing you need to do. You need to check, make sure they have a signed contract or agreement that they're going to get medications from you. Make sure that's up to date, and occasionally check urine tests. Make sure they're taking their medications appropriately. When you do prescribe them. And actually in California's pretty strict on this. Unfortunately, we do have a fairly large street drug problem. It is required that you prescribe naloxone, the nasal spray, if you combine a benzodiazepine like Xanax, lorazepam, Ativan with an opiate such as tramadol or oxycodone or Norco. It is required. It is the law that we prescribe the naloxone to save people if they overdose.
Or if they're getting a certain number of
or over a certain amount of
milligrams of equivalent to morphine.
Yeah.
Or if you just have any reason at all to suspect that could happen.
This is a higher risk.
Which is why some people do it
individual.
across the board for any opiate prescription. We also have a comment from Hilda Bauer. Hilda is asking, my pain management doctor refuses to prescribe extended release versus standard pills, saying they are more addictive. Why is that? I don't know if it's exactly that's going on. The OxyContin was extended release and it was very addictive, but it's because it was OxyContin.
Yeah.
Not because it was actually it's because it wasn't as extended as they were saying it was. That's what the problem was. So it may be referring to that. But I think the idea still stands that if you're using a long acting, because on my remaining patients who have chronic opioid use under prescription, it is with a long-acting morphine.
Yeah.
Actually, what would be called MS-Contin rather than OxyContin, which preceded it.
Right.
And the idea being that they're not going to have the effect of the medicine die down in the middle of the day and then they're hurting, which then encourages or leads to drug-seeking behavior because they hurt. And they get the reward of getting the pain relief. If you just keep them scheduled on a lower dose, not letting the pain get out of control, so they're just controlled through the day, then they don't experience feeling a need for medicine. That was the argument. I don't know how valid it is now that we've had the whole OxyContin episode occur.
Yeah. And we're getting away. It used to be have that long-term baseline one, kind of like insulin, right? You get this long-term baseline one with short acting for when you had these flares, and we're getting much further away from that, just having one medication on board instead of multiple. If you're in pain management, a lot of them are moving patients more towards buprenorphine or Butrans, or what's the other? Subutex, Suboxone, which is supposed to be because it it's not as addictive. I've heard people getting around to that and heard stories on the street saying
there's ways.
Yeah, there are ways to get around that, but a lot of them, that's kind of the newest way to try to treat pain that a lot of pain management's doing.
My understanding is that the buprenorphine is better than the alternatives as far as that goes.
Yeah, the way it binds to the opioid receptors.
Helping a person who's on the other opiates is unable to get off of them and may actually have chronic pain too.
Right.
The problem is they had this requirement of having to be trained through a certain kind of program and certified. I don't know if they still have that or not.
I don't think so.
And I think it's probably included that 12-hour.
Yeah, that was specifically for prescribing it for bringing people off of medication.
And now in California, is it California or is it for the DEA? Oh, it's the DEA. To renew your DEA, you're required, so this is the whole country, required to do 12 hours, I think it's 12, of training in treating addiction to opiates.
Yeah.
So that would probably include the Suboxone training.
Some information on that.
I haven't done it yet because mine doesn't renew until next year, so I've got a little bit of grace period here.
I was able to find the pain management course I went to, 10 years ago.
To count for it?
Yeah.
Okay.
Yeah, that's that way I was,
Okay, and then we have Lindsay Antwine asking, actually, she asked something before that. Why is it impossible to make a painkiller or class of painkillers that aren't addictive? Why is that?
Because, well, let's take a step back and first say what is a painkiller, right? There are absolutely painkillers that are not addictive.
And are quite effective.
We would call that Tylenol and
compete
ibuprofen.
against opiates very well.
Yeah.
By the way.
And actually, if you look at studies done where they compare blinded studies where people don't know what they're getting, you compare a combination of Tylenol and ibuprofen against Norco, which is Tylenol and hydrocodone. It's the same. They have the exact same effect when people are blinded, when they don't know what they're getting. So there is something to say about, there is a good effect of non-addictive pain medications. The problem is people's perception. That's the problem. People say, a lot of people say, I don't get the pain relief unless I have that narcotic. Or, Tylenol doesn't do it for me because I saw the name Tylenol on the bottle and not Norco. Maybe. But, they actually work really well. And people, and, you look back before we had all of these narcotics, that's what we were prescribing. Yeah. And people actually did all right. It's not that people were just silent and didn't have pain. No, people had pain back then too, and injuries were just as bad. But we had things that worked.
I would push back against that.
Tell me.
Because opium was around before Tylenol.
That's true. That's true.
And
we did, but mostly in a controlled environment. It wasn't on the street. Well, opium was, but I'm talking about like morphine we only had in the hospital. We didn't have an oral form of morphine for a long time. We didn't have, sure, you could do opium, but how many people were shooting up opium and reading opium? I don't know.
Yeah. And then the whole thing with combination of Tylenol and anti-inflammatories, great for pain relief. The problem, though, is many people that we're working with anyway, have problems with their kidneys that you're concerned about damaging that.
Absolutely.
If you use an anti-inflammatory.
Or they're on a blood thinner where you cannot take an anti-inflammatory.
Yeah, so that's why
we refer to Tylenol. Tylenol is actually one of the safest out there. Yeah. Tylenol, you can take up to 3,000 milligrams every day and be perfectly safe if you don't have any liver disease. Yeah. So even with liver disease, Tylenol is usually what you take, just at lower doses.
And then also for a painkiller, if the pain is from a nerve that's firing inappropriately, like with a lot of our back pain, the nerve coming out of the spine as it comes out, we can use medicine specific to that, anti-epileptics that work very well.
Yeah, absolutely.
Without having the addictive problems.
Mm-hmm.
Okay, and then I think we also had her throw in, and they actually kill the pain. And I think you addressed that with the...
Hopefully I did.
Tylenol studies that when people are blinded, they don't know. It's working really well.
Yep.
Tolerance. Tolerance just kind of came out there.
Tolerance, yes, is a thing. You can build up tolerance very quickly.
We need to address this perception that Tokyo Lloyd points out. Many people think that acetaminophen is terrible for the liver, and that's a misperception. It's because when people do die of Tylenol overdose, it is the liver. There is a liver toxin that occurs, but it's not Tylenol. Tylenol in normal dosing, 3,000 milligrams a day or less, doesn't have a liver toxin in its processing through the liver. It's when you have more than that amount that the liver uses up all of the substrate it needs to process Tylenol. So the next pathway that a chemical will take based on the concentration of Tylenol and other chemicals in the environment is one to create a liver toxin. So that's where that comes from. A normal liver that clears Tylenol prescribed in 3,000 milligrams a day or less, there is no toxin. And so it's a misperception that it's harmful to the liver in that environment.
Yes, absolutely.
Different from anti-inflammatory medicines that at normal dosing are harmful to the kidneys. Yeah.
Yep.
So that's why I'm very comfortable with Tylenol. Little cautious with the non-steroidal anti-inflammatory drugs.
Reach for the Tylenol. It's what I reach for when I have a headache.
Tokyo Lloyd thinks that 3,000 milligrams of acetaminophen seems sort of a lot. That's something else. The number of milligrams of something, if you're not familiar with it, and you don't have a reference for how many milligrams of something is the amount, you have no idea, because 3,000 milligrams of Tylenol is normal dosing. 100 milligrams of morphine is, oh my goodness, that's a crazy high amount. So the numbers don't
correlate.
Aren't useful to a person who doesn't know what the reference is
Yeah.
for the different drugs, because they're different and they have different potencies for different effects.
Even in the same classes of medications like blood pressure pills. We'll switch from one to another, and we'll have to go from a 10 milligram pill to a 25 milligram pill, and people say, oh, wow, you're pushing me up that much. No, actually, it's the exact same dose.
Less effect.
It's just a different type. Anyways.
Yeah. Metoprolol compared to carvedilol.
Yeah. Or I was thinking lisinopril to losartan.
Yes. They're very, very different. Or instead of losartan, one of those other sartans that goes up to 320. What's that? Benicar?
Benicar, which is...
Instead of going up to...
Tell you right now. Tell me sartan, maybe?
Yeah. So you can't tell by the number of milligrams anything. You have to know what it is for that medicine, what normal is.
And actually, if you think about it, if you ever have bought a bottle of extra strength Tylenol, those are 500 milligram pills. And it says to take 2 at a time, up to every 6 hours. We're not even taking that every 6 hours. 3 times a day would be 2 of those 3 times a day, or every 8 hours. So, or every 6 hours while you're awake. So we're not even hitting that. 6
caplets per day.
Yeah.
When in doubt, for over-the-counter, you can always just read the bottle. Make sure you're taking the right
There
amount.
you go. It usually says on it, do not take more than.
2 at a time.
Yeah.
And then Hilda was asking if that daily limit is right, because it sounds like a lot compared to, other medicines that are dosed differently.
Yep, absolutely.
Okay, so we're approaching the end here. Here we have another question from Tokyo Lloyd. So a healthy person can take 3,000 milligrams of acetaminophen every day indefinitely and experience no decrease in liver function.
As long as there are no external factors.
Yeah, if their livers, if there's not something else involved, there's not alcohol killing off their liver.
Yes.
The body should be able to reproduce or build enough of that substrate that's needed, or access it through where it gets it. I'm trying to remember what it was now. I can't remember my biochemistry from
CPA.
First year medical school. But that it may seem like a big number, 3,000, if you're not used to these numbers.
Yeah.
But absolutely. It used to be 4,000, and they lowered it because that was
pushing it. Yep.
That's too much, especially if it's going to be ongoing. There was a time I remember when 4,000 was the limit for acute treatment, and 3,000 was the limit for chronic.
Yep.
You probably don't know this.
Nope.
Not currently.
And then that was changed to let's just go 3,000 across the board.
Yep.
You're not going to get that much more pain relief taking 4,000 a day compared to 3,000.
And then if you want to do some comparison, there were people on Vicodin, which has 500 milligrams of
talk about
Tylenol, who were taking 8 of those.
Not 325?
That's Norco. But I'm talking about Vicodin specifically.
Oh, really?
For a while there, Vicodin's not available anymore.
Didn't know
but Vicodin is the 500s. There were people taking that 8 pills a day, daily, for their pain. So, that's more Tylenol than we're even talking about here. And if you look at Norco has 325 milligrams of Tylenol. A lot of Percocet has 325 milligrams of Tylenol. And there are people taking 8-10 of those a day. So, these are things where we are getting up to those limits, even with narcotics on board. So, I was once told, hey, why do they put Tylenol in those medications?
Yes.
Yeah, to make sure people don't overdose and kill themselves. Well,
how did that work out? Maybe that reasoning wasn't so good. And actually, I do know of people who, when they died from an overdose of an opiate, it was the Tylenol that did it. I don't know how many Vicodin I've taken. I'm losing count because of the opiate in it.
Yeah. Yep.
Take more Tylenol because it's in the opiate that I'm taking. So we're talking about the combination pills, Percocet, used to be Darvocet, that's not around anymore. You said the Vicodin, Norco. These are all combination of Tylenol with an opiate. And probably not a good idea, especially if somebody's going to be increasing it on their own. And that's the problem with these medicines, is people just keep increasing them to address something. Is it pain that they're addressing?
That's the question.
why is it they keep taking
Right.
it? When you give them opiates, why are they taking more?
Yeah.
People in pain
you
will
do
say
a
it's
lot of
because I
things.
hurt.
Yeah.
And that's the answer that we're given when a patient comes in the room and a prescription is made. It's because somebody's saying they're in pain and the other things that are being used, other things that are available are not adequate to address their pain. And I think we even had some comments in the chat to that effect of, you're not addressing my pain.
Yeah. But the underlying thing that we as doctors always need to consider is safety, addiction, tolerance. There are a lot of things to consider that when you walk around into a room and say, I've got this pain, treat it for me, it's unfortunately not as simple as that. I can take away your pain, but I'm probably going to kill you. If I were to give you a massive dose of something, yeah, I could take away your pain. You'd stop breathing. But we've got to think about safety, risk for addiction, tolerance. There are a lot of things going into that conversation.
Yeah. And when the person's in pain, it's
hard to hear that.
They are actually in a different state. There's a great book called Scarcity. I've talked to you about it before. Scarcity talks about how people think different in different situations. One of them is like financial. That'd be a scarcity of money. And they make decisions financially that are horrible, but make sense to them in the urgent need of scarcity that they're in, even though, if they were in the right state of mind, they would recognize, oh, that would be an awful thing to do. And then with pain, we see it too. Risk of addiction is not a concern when somebody's in pain. They hurt so much, and it's such a motivator that they'll do what it takes to get rid of the pain. You get that experience from the first dose of an opiate. And we even had somebody chat in here about, people being driven to the street. How safe is that? Why don't you just give them the medicine? It's because it drives them to the street. You're seeing the effect of it.
Yeah.
The best is not to use that at all. Well, it's challenging to work with pain when somebody can't take the regular medicines for it. Kidneys don't work, or allergy to medicines, or something like that.
Right. Yeah.
All right. And we're getting hearts here too. You can't see them on here, but they're happening over here. Dealing with scar tissues, my lower abdomen. Yeah. Okay.
Yeah. Some of those pain situations are hard because we do have to deal with or take into account all of those other situations. If you have bad kidneys, if you've got, if you, got some reason with addiction, and that's why a lot of pain management is moving towards non-pills, moving away from pills. And
Get away from pharmaceuticals.
Moving more towards, counseling, biofeedback, physical therapy,
TENS units,
implantable devices, lots of things, injections, those things that help. And that help a lot. And if you are in chronic pain, there's a lot to be said about finding alternative ways besides pain pills to deal with that.
Besides the opiates, yes. We would encourage anyone, in fact, you see it in our practice here, opiates. I can think of limited use of opiates, like somebody breaks their wrist. Yeah.
Short term.
12 pills.
These days you go to the ER, they're going to give you 3 days worth.
After that, we're going to be using the acetaminophen and the nonsteroidals.
Yep.
If there's a nerve component to it, we'll use the gabapentin rather than using the opiates.
Yep.
Yeah. Okay, so let's see what we had down here. Okay, I think that's all we're going to do on the comments. Any last comments from either of you two?
No. I feel for those people that are going through this, that are in the middle of
like the family member of our one of our,
that have been affected by that, or even the people who are currently in pain that are trying to find some way to feel better. Those are difficult situations.
And sadly, I don't have confidence that somebody who's hurting and in pain will hear the message of how bad opiates are in the long term. Again, short term, somebody breaks their arm, give them some opiates to get them through that acute pain. But after a few days, it needs to be addressed a different way. Otherwise, we've got bigger problems. Yeah. Okay, so I think that's it for today. Thank you for all the comments. We appreciate that, and all the hearts on the comment strip there. Thank you, Lindsay Antwine, for what you do to make this happen. Thank you, Stephanie.
Yeah.
You're welcome.
And Dr. Dwayne. Until next time,
see ya.
Stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.